Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hi, everyone. This is Bucci Nita from the Atlanta, Georgia area, and welcome back to the Skin Sync podcast. I'm very excited today to talk about this particular topic, Isotretinoin Hacks. We're going to go over some tips and tricks for a safe and successful management of acne patients on isotretinoin. And I'm especially excited because we have our very own in-house acne guru, acne expert, the illustrious Shanna Miranti. Welcome, Shanna.
Well, you are so sweet. Thank you, Bucci. It's so exciting to sit down with you and chat about one of my absolute favorite subjects, acne. I love treating acne and I love treating patients with isotretinoin, but it can be an incredibly intimidating thing to take on for a new APP.
Absolutely.
This is not something that we learn about in PA school. Typically, if we do, we learn a very small amount. And no one really teaches you about the little tips and tricks for prescribing isotretinoin in your practice. How do you go about scheduling those patients? How do you go about making sure that there's room on your schedule 4 weeks later? So these are things that a lot of us have had to learn along the way. So I now love going out and teaching about these isotretinoin hacks that I've learned in my 23 years plus of prescribing this medication. And it's such a life-changing medication, Bucci.
It's one of my favorite things to prescribe in dermatology.
Absolutely. I agree. And I think that if you talk to people who are passionate about it, they will all agree. But there's a huge camp out there of dermatology APPs and dermatologists that just say nope, and they throw up their hands and they say, I don't want to prescribe it because it's kind of a pain in the neck sometimes to go through the hoops that are necessary to jump through.
Well, that's unfortunate, but hopefully we can convince them otherwise today. So let's kind of go over some of the basics of isotretinoin. Give us the MOA. Do we know the MOA of this medication?
Absolutely. So isotretinoin is a synthetic derivative of vitamin A. So I tell patients that it is not some toxic chemical, but it is a vitamin A derivative that actually creates apoptosis of the sebaceous and meibomian gland cells. So it's actually physically destroying those cells and reducing the sebum production in the skin. There are 4 pillars of acne pathogenesis, as we all know. And that excessive sebum production is very, very tricky to get under control. There's actually only 3 medications that reduce the sebum production: isotretinoin, spironolactone, and clascoterone. So if you have an extremely oily patient or a patient that's getting a lot of the follicular hyperkeratinization and plugging of those sebaceous glands because of that excessive sebum production, you need to be using one of these 3 medications, or we're never going to get to the bottom of the oil gland or sebaceous gland conundrum. So this is a medication that actually tackles all 4 pillars of acne pathogenesis: follicular plugging, inflammation. It is able to stop C. acnes reproduction and growth because it basically cuts off their food source. It reduces that excessive sebum production by destruction of those oil glands.
And I think that's a lot of why we get the long-term results with isotretinoin, right? Because we're destroying that sebaceous gland, right?
Absolutely. So you can have long-term improvement because you're going to have longevity of the reduction in that sebum. Some of the patients will get nervous about that. They don't want to be dry forever. And so I often tell them it is something that they will often regain some of their sebaceous activity, but their skin will truly be forever changed in a good way.
Absolutely. So one of the biggest barriers for me, certainly for my colleagues, my clinic, it gets one of the biggest eye rolls from my MAs at 4:30 in the afternoon as we're trying to close out clinic, is the documentation piece when it comes to isotretinoin. I mean, it's obviously critical that we make sure that we document that counseling, we document the side effects that we reviewed, but it can be quite a headache, and it can kind of put you behind with your charts. So what is your approach to really making that documentation very concise and a little bit faster?
This is a huge isotretinoin hack. It's really important to set up protocols, and not only to have protocols within your EMR system, but also have protocols within your scheduling system. If you're able to adjust your template for scheduling future patients, this is a patient that you are going to have to see back every 4 weeks. The FDA only allows us to release 30 days of medication at a time. So we are going to be seeing these patients every 4 weeks. So it's critical to have not only the documentation piece, but also the scheduling protocol set up. As far as documentation goes, I love using protocols within Emma. We've actually discussed this on previous podcast episodes. Really, really important to set up your specific protocols. I have a registration protocol for females on isotretinoin. I have an initiation protocol and a follow-up protocol. Now, you want to make sure that your MAs are going in and adjusting things and changing things, especially that isotretinoin monitoring button. Make sure that you are adjusting the monitoring for the month that you are actually on. And that will actually help you calculate your cumulative dose. So it will actually keep track of a lot of that for you. So make sure that you're using specific protocols, but then make sure that if you do, say, discuss hypertriglyceridemia within that visit, or if the patient has angular cheilitis or dry skin or something else that you're discussing, make sure that your MAs know that they need to add to that protocol and make it very specific for that patient in that visit.
Absolutely. And one other mention is if you have Emma and you're documenting an isotretinoin visit, a follow-up visit, using the right chief complaint. It really just makes your life easier. It has a checklist of questions, and it's very thorough. So just something worth mentioning. Okay, so let's talk about one really helpful tip is the pharmacy. I think it used to be that we would just send it to any local pharmacy and get this prescription filled. I have moved away from doing that completely in my clinic. What about you?
Absolutely. I could not agree more. I for sure operate under the thought that friends do not let friends use big box pharmacies for isotretinoin. It is so incredibly important to make sure that the provider is going to reach out to specialty pharmacies in your area that are able to deliver this in a very timely manner to your patients. I want next day delivery because I want to make sure that those iPledge windows do not close. For those of you who are new to isotretinoin prescribing, you do have to become an iPledge prescriber. It's very, very important to be very familiar with the iPledge system and with all of their specific windows and their very specific time windows. Certain things can be delegated to MAs in your office, and you can sign up medical assistants, nurses, RNs, or other providers as either delegates or designees to act on your behalf within the iPledge system, which is actually very important if you're going to be on vacation
100%.
or out on maternity leave or something. You need to have another prescriber that's able to have access to confirm your patients. However, you need to be very, very knowledgeable about those windows. And as soon as that confirmation occurs within iPledge, you need to let the patient know they have to have drug in hand within 7 days of that confirmation. So when I reach out to my specialty pharmacies, I want to make sure that when that confirmation happens, when I see that patient, when I do that UPT in office, or when I review that lab work and I'm confirming that patient, that they are able to get meds in hand the next day. Also, I would like to make sure that there's continuity of care with what we are prescribing. It's really, really important to not have them bounce to different generics because all of them have a different absorptive potential.
Right. And one thing I'll mention is when something goes wrong in iPledge, it's always our fault, right?
Of
Even if
course.
it's not our fault, it's always our fault. So I think it's especially important, again, that you have a good partner pharmacy that you work with that's going to get that medication delivered very efficiently and get your patients involved too. Make sure they understand those timelines as well.
Absolutely.
So let's talk about some of the updated AAD guidelines when it comes to managing acne, specifically with isotretinoin. What makes a good candidate? I think in the past, at least when I was training, it would be severe acne, cystic acne, scarring acne, but I think there's been some shift in that. So what's your approach to choosing the right candidate?
So the AAD finally released new guidelines for acne management in 2024. And the isotretinoin section of these guidelines specifically mentioned, of course, patients with scarring. And I think that is one of the biggest things. If we see scarring, but not only permanent acne scarring, but a lot of times that very persistent hyperpigmentation that can be very bothersome, especially for our patients that have darker skin tones. Also, patients with psychosocial burden should be considered candidates for isotretinoin. There have been some shifts and some changes about monitoring. In these new guidelines, the AAD now recommends monitoring only LFTs and lipids. And actually, they mentioned specifically that population-based studies have not identified an increased risk of neuropsychiatric conditions or inflammatory bowel disease with isotretinoin. Of course, for persons of pregnancy potential, pregnancy prevention is mandatory. So this is something that you have to counsel your patients on if they have the potential for pregnancy.
Absolutely. I really want to harp on that psychosocial burden aspect of it because, again, it's not just severe acne, it's not just scarring, but it's how much it bothers the patient. If it's distressing, I have several patients with acne excoriate where they will pick at their lesions. It might be more moderate acne, but it's really disturbing to them. I think that's an isotretinoin candidate for sure. Severe hyperpigmentation. If it's bothersome to the patient, it's a bothersome to me. So we're going to go ahead and move forward. And
Absolutely.
especially now with antibiotic stewardship, I think it's really important again that we don't reserve isotretinoin for that last resort.
For sure. So don't only include your severe patients in the category of isotretinoin candidates. Make sure that any moderate to severe patient who has a psychosocial burden, who has scarring, or who, has the potential to really, you see that they're on a trajectory, toward a very potentially bad future path, make sure that they are going to be at least offered isotretinoin as a treatment option.
All right. So one of the most critical parts of managing this medication is that patient counseling, right? Because we have to get buy-in from the patient or the parents, right? And also just ensuring that they have a successful treatment, that they have the fewest amount of side effects possible. What does that conversation look like for you? What are you telling your patients about the side effects?
So this is a very big isotretinoin hack. Make sure you are very comfortable about counseling. Patients are going to come in often with a lot of misconceptions and a lot of preconceived notions, and they may not be evidence-based. In fact, most of them are usually not evidence-based. Oftentimes, it is a friend or a neighbor or a cousin who was previously treated with isotretinoin, and they're receiving a lot of misinformation from other sources. Maybe they were even talked to about this by a previous provider, but were not given enough information. So it's our job to do adequate counseling and to be very, very comfortable with the most common AEs that are often seen with this medication. We know that actually the top 4 AEs all have to do with dryness. Dry lips, dry skin, dry eyes are some of the most common side effects that we will see. If you practice in the Southern Hemisphere, you're also going to have photosensitivity up there, very, very high up on the list. Worsening of acne, and actually sometimes that dreaded purging that patients are so worried about, is one of the top 5 side effects that is reported with this medication. So in addition to musculoskeletal complaints and soreness, dehydration, etc. So we need to make sure that we are adequately counseling these patients. Also important is what's not on that very common AE list. Sometimes they're going to come in hearing the most obscure side effect that's rarely ever seen, and they're so nervous about that. So you need to be able to act with a lot of confidence and be able to counsel your patients, whether it is a common AE or whether it's not.
Right. And so, what are your go tos? You have a patient who you know is going to have dry skin. Perhaps they even have a history of a little atopic dermatitis. What sorts of moisturizers are you recommending? Do you recommend eye drops? Do you recommend supplements? What do you go to?
Oftentimes, I will have a pre-printed do's and don'ts list. In fact, this is a must-do. It's a very important isotretinoin hack. Make sure you have something tangible that they can leave your office with, even if you're just starting to plant the seeds about potentially future treatment with isotretinoin. Make sure you're letting them know dryness is expected. We do actually expect it to happen. So we want to make sure that they have things prepared for their lips, whether it's a petrolatum-based lip product or some other type of sample that you can tangibly give them in your office so that they have something to go home with and they can start using right away. I love either the lipid-based moisturizers or ceramide-based moisturizers, but it's very important to also make sure that you are telling your patients not to use anything comedogenic that could potentially make the acne worse. We don't want them going home and slathering beef tallow all over their skin when they're on isotretinoin, or they may not get a great outcome. So make sure that we are preparing them with great products. Luckily, so many of the companies now are able to bring samples to our offices. So we're able to give them a really good cleanser that does not contain salicylic acid or glycolics or benzoyl peroxide, something that would additionally add to the dryness. Really good foaming cleanser and a really great lipid or ceramide based moisturizer is oftentimes what I'll recommend.
Excellent. And for muscle aches, body aches, you like to do ibuprofen as opposed to acetaminophen, correct?
That is
Okay.
correct. I usually recommend ibuprofen. We do know that isotretinoin is metabolized by the liver. So I specifically tell patients that I do not want them taking any other medications metabolized by the liver because we only get one liver. We don't want to make it mad while they're on this medication. So I actually, on my do's and don'ts list, I have that specifically listed. No alcohol, no Tylenol, because of the potential for liver inflammation.
And while this is not in the AAD guidelines, but I think there are publications out there that support using omega-3 supplements if you do have a patient that's really having a hard time with the dryness. There are some recommendations in publications for using over-the-counter antihistamines like loratadine and cetirizine to help reduce the purging that comes with that initial dosing of Accutane, right?
Yes, and I've been actually very impressed by patients who have heard about that and come in asking about it. I certainly think it can help prevent some of that initial purging. And you brought up a great point about the omega-3s. We know that vitamin A is a fat soluble vitamin, so it's very important to actually take this with a healthy fat. If you have a patient that is not a big consumer of dietary fats, they may want to take this along with a omega-3 supplement. That way they are getting a good omega-3 at the same time that they're dosing their medication. The medication needs fats in order to get 100% absorption.
That's helpful because I actually tell them to take the omega-3s mainly for the dryness, but I didn't think about it as a source of fat for consuming the medication. How do you recommend them as far as diet and counseling goes? What are you telling them to do as far as fat sources? Obviously, they can have a double bacon cheeseburger or they could have, half an avocado. So what are you telling patients typically?
Correct. So usually we're talking to teenage patients or younger patients at this point, and they probably don't have the best diet to begin with. So oftentimes I'm telling them, hey, I would really love you to take this with a healthy fat, a half an avocado, or of course your omega-3 fish oil supplement, or eggs, and good healthy animal sources of fat. However, I do kind of joke sometimes and I say, hey, if you're going to be going through the Chick-fil-A drive-thru, take it with your French fries because that counts too. And we joke about it, but we do know that dietary fat is important for adequate absorption, especially if they're using the traditional generic sources of isotretinoin. The low-dose version does have better absorptive potential.
And one thing I'll mention that I find challenging sometimes, the medication is often dosed twice daily, right? Depending on where you're at. Patients aren't eating breakfast. Many patients do not
Right.
eat breakfast. They skip that meal. And so for my patients, it's important for you to take it with fat. I'd rather you take both tablets at the same time in the evening with your heaviest, fattiest meal to really enhance that absorption. Is that your same recommendation
So
typically?
I do typically try to get them to take it BID.
Right.
We know that sometimes actually the best absorption can oftentimes be in the morning with that first meal.
Right.
But if we do have teenagers that are running out the door and not eating or not able to get breakfast at their school, that's when I'll really try to make sure that they have something prepared, maybe little egg bites running out the door or a breakfast sandwich or some kind of like a good protein bar that might have nuts if they're not allergic, to where they are getting some source of a good fat. A good old scoop of peanut butter on a spoon works just fine, when
Yeah.
they're walking out the door in the morning too. So as long as they are consuming a little bit of dietary fat, they're going to get better absorption. And I do like to keep consistent blood levels throughout the day, although certainly you do want them to consume it with their highest fat meal.
Okay, well, that's really helpful. So let's kind of talk about dosing. Dosing in the sense of trying to reduce that purging, especially for patients that have really severe cystic acne. Dosing to try to enhance that long-term clearance and remission of the acne. And how do we know when it's time to stop?
These are two very important isotretinoin hacks. Number one, knowing a typical course and what a traditional course looks like. I typically will start off with a 0.5 milligram per kilogram of body weight and usually start out at a QD dosing once a day in the morning, again, along with a dietary fat or an omega-3 supplement. Then I will traditionally check blood work at the end of that first month to check their LFTs, to check their lipids, just to make sure there's nothing out of the ordinary, to make sure that we don't have a patient that's on a, ridiculously high amount of creatine that could also be burdening that liver, or making sure that patients' triglycerides aren't really going up. As long as those labs look fine, then I'm putting them up to a 1 milligram per kilogram of body weight. But it's really important to start low and go slow, especially with patients that are younger and have a really, cystic or very, potentially inflammatory type of acne. We really want to reduce the risk of pseudoacne fulminans. So make sure you start at a low dose. There's entire lectures just on pseudo-AF. So make sure that you're very comfortable with a start low, go slow protocol. But I do like to try to make sure that we are getting to the end of that course and checking 3 specific boxes. You want to make sure your patients, number 1, have been on at least 20 weeks, a 20-week minimum. Make sure, number 2, you have reached a cumulative dose range of 120 to 150 milligrams per kilogram of body weight. And number 3, make sure that they are completely clinically clear for at least 1 month, or preferably 2 months before you stop therapy. If they have not gotten to complete clinical clearance, go another month, even if you have to drop down to a slightly lower dose, and trimming that dosage at the end of therapy. I would rather add 1 month onto their course than have to have and risk the potential of future repeat courses unnecessarily in the future.
I think it's so important. I think we oftentimes get, especially us more veteran clinicians, are stuck in that 5 months of treatment. And again, you're not limited by that. Treat until clear for at least 1 month of clear skin is really, really important.
Do you ever get any questions about microdosing? I feel like this is a big hot topic right now.
I have not actually. Tell me about that.
Yeah, so a lot of us that treat with isotretinoin quite frequently are getting patients that are coming in asking about microdosing. They might have heard about this on social media. They want to come in and take very, very small doses, potentially for a very, very long time. Although I do consider microdosing a good option for some of my male patients, it really becomes very burdensome for our patients of pregnancy potential, because you do still have to keep up with all of the iPledge rules the entire time that they're on it. And then oftentimes it's going to take them a very long time to get to that cumulative dose range of 120 to 150 milligrams per kilogram of body weight. So if you have patients that come in asking about microdosing, make sure that you have looked up some of the journal articles that are discussing this, and make sure that you're very comfortable counseling them on potential alternative courses and alternative doses. My rule of thumb is usually get them clear at the traditional dose, and then we can potentially consider microdosing after the fact.
Great advice. So my final question for you, Shanna, is post-Accutane. Do you leave your patients high and dry and I'll see you next time? Do you put them on a maintenance plan? What is that maintenance plan? Tell me more.
Yes. So this is definitely one of those, lessons that oftentimes providers will have to learn for themselves. They're going to have to learn when do we stop, and then what do we do after? There is no textbook that tells you what to do when a patient has fully gotten clear. So I think one of the most important isotretinoin hacks at the end of the therapy would be to actually start patients on a topical retinoid, and it can be a topical retinoid of your choice, but there are some really good peer-reviewed journal articles out there about using topical retinoids even the night that they take their very last dose of isotretinoin. Okay. So that's my protocol. That's what I was taught, and what I've learned, and what I've done in my research, to start them on a topical. This not only, number 1, prevents some of the future breakouts that may start to come back when we do get some sebaceous gland activity again. But I also do like to give them the reassurance that we're going to start working on any potential PIH and scarring right away. And we're going to start working with a topical retinoid that maybe has some data to show that it can reduce acne, scarring, and or PIH in the future. So I do love to use the medications that have done clinical trials and have data on just that.
So Shanna, as we close out, I'm going to just let you know that no matter how many times I hear you speak about acne, I learn something new every single time. This has been fabulous. I hope you guys took some really great tips from this, and listen again.
Thank you so much, Pooji. It's always a pleasure to sit with you and to chat about dermatology. So until next time.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.